By the end of this video, you will be able to choose the right answer as we cover one of the most high-yield topics for the USMLE and psychiatry boards, neurocognitive disorders. Now, you have to know the difference between major and mild neurocognitive disorders because you will be tested on this. Mild neurocognitive disorders, there's a moderate decline with difficulty with ADLs, but their independence is preserved. Major neurocognitive disorders or dementia, the patients need help with ADLs, meds and finances, and their decline is so severe that they do eventually need help with the ADLs as well. There's two high-yield screeners. One is the mini mental status exam. A score less than 25 suggests dysfunction. And then there's the mini cognitive exam, which is a 3-item recall plus a clock drawing. And it's positive if 1 to 2 items recalled with abnormal clock. Alzheimer's dementia is the most common type of dementia, and you need to know the clinical presentation. These patients are going to have a gradual progressive decline. The core domains affected are memory, learning, and language, and these patients can also show personality changes and paranoia. Now, it's also important to know what does this look like on a histology slide. So these patients are going to show amyloid plaques and tau tangles. I have a picture here, but I recommend you Google several images so that you can recognize it on the exam, because they may just show you the histology slide and ask, what is this? You also need to know what does this look like on head imaging. So these patients are going to show cortical atrophy and enlarged ventricles. Alzheimer's dementia affects the hippocampus. So how do we treat Alzheimer's dementia? There's no cure for it. There are some medications that can help with memory a little bit. They're not that great. So first line for these medications is the acetylcholinesterase inhibitors, such as donepezil or rivastigmine. And you can also give them memantine, which is an NMDA antagonist. Memantine is more for the moderate to severe cases. Again, none of these are that great, but you might get asked, what medication should I use in this elderly patient with Alzheimer's dementia? And it will be one of those medications. Remember the mechanism of action because they may just ask about the mechanism of action. In elderly patients that become agitated, you have to remember that there is a black box warning, patients with dementia. So vascular dementia is the second most common cause of dementia. And the etiology is that it is caused by conditions that damage the brain blood vessels, reducing blood flow and oxygen to supply the brain tissue. And when we think of this, we think of cardiovascular disease that affects the large and the small vessels. Now, these patients are going to have a stepwise deterioration. The key domains that are affected are complex attention and executive function. You need to know what this looks like on an MRI because this is frequently tested. There's multi-infarcts and there's going to be these hyperintensities, these little white marks in the brain. So Google several images of this so that you know what it looks like for the exam. How do we treat? There's no cure, but there is secondary prevention. So we can control the patient's hypertension, we can lower the lipids, manage the diabetes, tell the patient to stop smoking. All of these things will just decrease the damage that's already being done. You need to know Lewy body dementia. It frequently shows up on exams even though it's not that frequent in real life. Clinical triad for Lewy body dementia is fluctuating cognition, waxing and waning attention, visual hallucinations, vivid and well-formed, Parkinsonism, tremor and rigidity. Now, it's important to note that for Lewy body dementia, the Parkinsonism, tremor, rigidity, motor symptoms start at least a year after the cognitive decline. And this helps us distinguish Lewy body dementia from Parkinson's disease dementia. In Parkinson's disease, the motor symptoms will start first, whereas in Lewy body dementia, the cognitive decline will start first. You need to know what this looks like on a histology slide. Now, the vignette might describe alpha-synuclein Lewy bodies, or they might just give you a slide. So I have a picture here, but look it up on the internet so you see several pictures and can recognize whatever they show you on the exam. You also need to know that these patients have antipsychotic sensitivity. They can have severe life-threatening reactions to typical antipsychotics like Haldol. So if you must give them an antipsychotic, you could give them quetiapine or clozapine that are less likely to cause Parkinsonism symptoms. Or, and this will show up on ABPN and PRITE, pimavanserin is specifically for hallucinations in Parkinson's. So if that is an answer choice, click on that. We'll discuss frontotemporal dementia. This dementia is characterized by an earlier age of onset and personality change. Now, there are two main variants, and the first one is the one that you'll most likely be tested on. And this one is the behavioral variant. So in these patients, they're going to show disinhibition. They're going to be socially inappropriate. There's going to be apathy and loss of empathy, and they're going to be eating things that they shouldn't. The second variant is the language variant. These patients show primary progressive aphasia, and they have impaired speech and comprehension. You do need to know what this looks like on imaging. So pathology, there's going to show focal atrophy of the frontal temporal lobe. It's going to have this knife edge atrophy. I have a picture here, but you need to look up a few of them before you take the exam. So how do we treat this? The focus is on behavior. Like many dementias, there is no cure. Meds are SSRIs or trazodone, and the goals of these meds is to decrease the impulsivity and the disinhibition. Next, we are going to discuss prion disease. Creutzfeldt-Jakob disease is commonly tested on exams. You need to know the clinical hallmarks. The onset is rapidly progressive. That is a key that this is a prion disease. Also, most patients will show myoclonus. So if someone is having myoclonus, which is sudden jerks, often startle-provoked, and their disease is rapidly progressive, it's probably prion disease. Other symptoms include ataxia, visual disturbances, and akinetic mutism. Now, the prognosis for this is incredibly poor. Most people will die within a year. You do need to know histology for this disease. So the histology will show spongiform change, which is small, rounded follicles in the neutrophil, neuronal loss, and reactive astrocytic gliosis. I have a picture here, but again, you need to look up several pictures so you can recognize it on the exam. Next is normal pressure hydrocephalus, or NPH. Now, normal pressure hydrocephalus has the classic triad of the 3 W's. That is wobbly, wet, and wacky. So when we talk about wobbly, we are talking about the gait disturbance. These patients are going to have a slow, broad-based magnetic gait. Wet is describing the urinary incontinence. They have urgency leading to a loss of bladder control. And then wacky is the cognitive impairment, apathy, executive dysfunction. You do need to know what this looks like on imaging. So for imaging, there's going to be ventricular megaly out of proportion to atrophy. You can see how huge these ventricles are here. That is a key sign that this is NPH. So how do we treat this? Because we actually can treat this. We can use a VP shunt. And the VP shunt will lead to draining excess CSF to improve the person's gait. Next, we're going to discuss Parkinson's disease dementia, and it's so important that you be able to distinguish between Parkinson's dementia and Lewy body dementia. For clinical presentation, the motor symptoms are always going to show up before the cognitive decline. Unlike Lewy body dementia, where the cognitive decline occurs before the motor symptoms. The core deficits are executive dysfunction and visual spatial impairment. Now, you need to know what these motor symptoms look like. There's going to be the resting tremor, cogwheel rigidity, akinesia, which is slow movement, and postural instability. You also might get asked questions on how to treat Parkinson's dementia. And you can treat the cognition with cholinesterase inhibitors, like with Alzheimer's disease. But if the patients have psychosis, you're going to treat it like if they had Lewy body dementia, like we spoke earlier. So you don't want to use typical antipsychotics because it will worsen the motor symptoms. You can use quetiapine or clozapine. And those used to be the old school answers. Now that we have pimavanserin, that will always be the answer if it shows up on the exam. Again, it's a very expensive drug, so it's not actually used that often. Now we are going to get into the critical differential diagnoses, delirium and pseudodementia. So starting off with delirium, delirium is going to show an acute onset, hours to days. It is often the first sign of an illness. The course fluctuates. Unlike dementia, which is very persistent, you're going to see a fluctuation in symptoms, particularly worse at night. Hallmarks include decrease in attention and awareness and disorganized thinking. You're going to see these patients show a lot of confusion. They can even have visual illusions and hallucinations. About 90% of hospitalized dementia patients get delirium. So it is possible that your dementia patient is having delirium in addition to the dementia. It is important to look for signs of a medical disorder that could be contributing to delirium. So if the vignette shows a patient with a UTI, elevated white blood count, fever, you want to have delirium high on that differential. What is the treatment? Fix whatever the cause of the delirium is. If it's a UTI, give them antibiotics. You want to avoid benzodiazepines in delirium because it can make delirium worse. The one exception is delirium tremens due to alcohol withdrawal. In that case, benzos are the treatment for alcohol withdrawal. Next, we'll get into pseudodementia. So pseudodementia is depression, which can look very similar to dementia in elderly patients. But for dementia, it is a slow onset, whereas in pseudodementia, it's more acute. The awareness in dementia, the patients are unaware. They confabulate to make up for what they don't know. Whereas in pseudodementia, they initially say, I don't know, but if pressed more, they will give you the answer. The course for dementia, there's no improvement with medication. So you give them an antidepressant and there's no improvement in their cognition. Whereas with pseudodementia or depression, the cognition improves with giving them something like Lexapro or sertraline. Sundowning is very common in dementia, but it is uncommon with pseudodementia because it's actually depression. There are a couple of high-yield rule-outs when assessing for cognitive decline. One is thyroid dysfunction. Thyroid dysfunction can mimic dementia symptoms, so you want to check TSH, free T4, and T3, and then vitamin B12 deficiency. In these people, you're going to see a cognition decline as well as paresthesias. Now, these are just a couple of things that you need to rule out, but they are the most high yield. Subscribe to get notified about new videos every week. Here's a playlist to help you with other high yield topics for your exam. Good luck.